Assalamualaikum warahmatullahi wabarakatuh and salam sejahtera to all the consultant. To all the consultant, the EPs and also the members of the floor. So today I'm going to present on the very first journal club lah, basically. So my topic of presentation is I'm thirsty, which drink you want to serve me? So I think it's self-explanatory. Basically, what I'm going to present is what I'm going to present is essentially the fluid choices that you have in fluid resuscitation. So these are my outline of presentation. I'm going to touch a bit on introduction, and then I'll be talking about crystallite versus colloid, the normal saline versus balanced crystallite, which is Hartmann or Lingus lactate, then Hartmann versus serofandin. I'll touch a bit on albumin, then sodium bicarb, and fluid to avoid. So let me start off with the introduction. So basically, fluid resuscitation is actually a very crucial aspect in emergency treatment and also in critical care. In fluid resuscitation, basically the mainstay of the treatment for severe hypovolemia. So when patient has loss of blood or extracellular fluid, this will lead to reduce in peripheral perfusion, leading to severe hypovolemia. And the resultant of organ dysfunction from the inadequate tissue perfusion will result in hypovolemic shock or septic shock. If fluid resuscitation is not given adequately, the ongoing ischemic injury will lead to irreversible shock and eventually multi-organ system failure. So basically, in fluid resuscitation, the aim is for volume expansion, and then subsequently this will increase in the stroke volume and eventually the cardiac output. Okay, so for the principle of management in fluid resuscitation, basically we have three: to identify and treat the etiology, to identify the electrolyte and the acid-base disturbances, and to assess and treat the volume deficit. This eventually will decide on the choices of fluid to be given to the patient and also the rate of fluid to be given. So what I'm going to talk about here is actually the choice of fluid that we can give in fluid resuscitation. So for fluid resuscitation, basically we have three major component lah. So one is crystallite, such as the saline solution. The balanced solution include Ringer's lactate or Hartmann, plasmalite, our isotonic bicarb, and serofandin. Some ED have serofandin, but some of the ED tak ada serofandin lah, because serofandin is a bit expensive. Then we have colloid containing solutions such as the albumin solution. We have 20% and we can dilute it to make it 5% or 4%. And there is hypooncotic starch, for example, and also dextran. And we also have blood products or blood substitutes such as our platelet, cryo, FFP, and then PEG cell. So for the choice of replacement fluid, essentially is according to what type of fluid that we lost. So for hemorrhagic shock or for bleeding, we can actually replace with blood products. And for non-hemorrhagic shock, or shock not due to bleeding, we can choose either crystallite or colloid containing solution. Okay, for severe volume depletion or hypovolemic shock not due to bleeding, essentially our first line is crystallite solution. So there are a few studies, showing crystallite versus colloid solution. There is SAFE study in 2006, Crystal in 2013, and Albios study in 2014. So for SAFE trial, basically this is a comparison of albumin and saline for fluid resuscitation in ICU. So it's a multi-centered trial using 4% of albumin solution versus the normal saline. Okay, so basically the primary outcome measure was the death from any cause during the 28 days period after randomization. So essentially for this, it has a similar result between these two, 4% albumin or normal saline. Okay, and then multi-organ failure, the duration of hospitalization, also the effect upon systemic pH were also noted to be similar. Then there is no differences observed in subgroup analysis of patient with or without sepsis. Okay, however, in a patient with head trauma, resuscitation with albumin was associated with higher mortality. So basically kat sini shows that no significant difference between the two except in those in head trauma patient. So this crystal trial pula, this is an effect of resuscitation with colloid versus crystalloid on mortality in clinically ill patient presenting with hypovolemic shock. Okay, this is a multi-centered open label trial lah. Basically, this trial shows no difference in 28 days mortality and then the need for renal replacement therapy. However, it's noted that the colloid use had more days of free ventilation and vasopressor therapy use and lower 90 days mortality. Okay, however, because of the open label design, the lengthy study period, it took 9 years for this study, and the heterogeneity of the fluid. Basically, in this study, there are multiple fluids used for both colloid and crystalloid. Okay, you can see here for colloid, they use gelatin, dextran, HES, even albumin, and then multiple types of crystalloid use also. So this actually limits the confidence in the possible benefit of using colloid in this population. Okay, in the last study, the Albios, which is in 2014, this is basically study in albumin replacement in patient with severe sepsis or septic shock. It's a randomized control trial, multi-centered, open-label trial. So here noted that the use of 20% albumin in adult with severe sepsis will improve the hemodynamic indices, but will not reduce the mortality. And its use is safe, but not recommended for fluid resuscitation. And also targeting the serum albumin of 30 gram per liter or more does not appear to have any survival advantage. Okay, so basically evidence from the randomized trial and meta-analysis has no convincing difference between the crystalloid and albumin solution. So for this, we actually point for crystalloid for the lack of clear evidence and higher cost of albumin. Okay, so these are just table to show various colloid available and the possible side effect. You can see that albumin solution actually have the least possible side effect to compare to other colloid. Other colloids such starch can lead to renal dysfunction, coagulopathy. Mostly, it can lead to allergic reaction and anaphylactic reaction. So this also dextran, same. Okay, then gelatin, and then this one crystalloid lah. Okay, so we move on to basically normal saline versus buffered crystalloid. So in buffered crystalloid, I'm actually talking about Hartmann dengan Rayner's lactate lah. So normal saline actually is not normal. It's not actually, it's actually acidic, okay? The pH is actually 5.7. What else is acidic? Contohnya coffee. Coffee is acidic. So the content of a normal saline mainly is sodium dengan chloride. However, for Hartmann or buffered crystalloid, dia ada banyak other constituent beside sodium and chloride, and the content for sodium and chloride tu less than the content yang ada dekat the normal saline lah, and the pH is less acidic. If you see from here, you can see that actually the balanced solution, dia punya osmolarity is more or less about the same as the plasma. So that's why we call it as balanced solution to compare to normal saline which has higher osmolarity. And then kalau ikut kat sini, normal saline memang ada sodium and chloride je, but the rest of the balanced solution ada other constituent juga. Macam contohnya Hartmann or ringan lactate, dia ada potassium which is about the same, and then dia ada calcium. Okay, so other things about normal saline is that it is effective and also inexpensive. However, actually, normal saline ni dia promote acidosis because of the high chloride content. It can lead to hyperchloremic metabolic acidosis, which actually nagma lah. Okay, so hyperchloremic metabolic acidosis ni actually can lead to eventually hyperkalemia juga, because if you remember our basic science, for metabolic acidosis, there will be a shift in like the, what you call this, the hydrogen ion, dia akan masuk to the cell, and then the potassium dia akan tukar keluar from the cell. So eventually you akan dapat hyperkalemia. Okay, other things about normal saline is that because of the high content of the chloride, actually this boleh menyebabkan renal vasoconstriction, which actually can lead to AKI lah theoretically. And also it has been shown to start an inflammatory cascade in animal model. Okay, other things about buffered crystalloid, the Linus lactate and Hartmann, is that certain medication cannot be run together. Okay, because buffered solution ni dia ada precipitate, dia boleh create precipitant because dia ada calcium. So these are some of the medication yang cannot be given together. So kalau you nak bagi boleh, but at different line or different limb. But kalau untuk neonate, macam ceftriaxone ni memang should never be running at the same time in the neonate. Even different line or different limb pun tak boleh. Okay, other thing is that because of the lower content, if you are giving patient a high volume of buffered crystalloid, it can lead to hyponatremia. It's just that because sodium is lower to compare to normal saline lah, punya sodium content. Okay. Okay, so we have some of the myth of Linus lactate. So it is said that using Hartmann ataupun Linus lactate ni can cause lactic acidosis. Sebab dia kata ada lactate, so boleh menyebabkan lactic acidosis. Okay, actually Linus lactate ni, Linus lactate ni contains sodium lactate. And the sodium lactate ni is not an acid. It is actually a buffer. Buffer tu adalah weak acid or weak base kan. And this lactate, dia akan metabolize by the body and hasilkan bicarb. So actually it does not contribute to increase in lactic acid. So dia boleh guna actually untuk patient yang ada lactic acidosis. Lagi satu myth is that it can worsen the hyperkalemia because dalam ringan lactate ni dia ada potassium kan. Dalam normal saline tak ada potassium. Tapi actually the potassium composition is actually physiologically closest to the human serum. Macam I cakap tadi, just now Audit mentioned that the Hartmann or Linus lactate, dia punya composition lebih kurang sama dengan what we have in our plasma. So actually it has a negligible effect. Okay, and then the potassium volume of distribution juga is greater in extracellular fluid. So basically tak ada effect sangat dekat potassium and hydrogen ion punya gradient. However, it is said that alkalinization, because Linus lactate ni dia ada 28 milliequivalent per liter of bicarb, actually may drive potassium into the cell. This is macam terbalik dengan what acidosis does. Basically kalau dia alkalinize, the potassium basically dia akan masuk because of the hydrogen ion keluar daripada sel. So overall dia akan reduce the serum punya potassium level lah. So essentially it is safe to be used in patient with hyperkalemia. So actually Linus lactate ni boleh guna untuk dua-dua, patient yang ada hyperkalemia ataupun patient yang ada lactic acidosis. Okay, so these are some of the trial. These are some of the trial yang available between the usage of normal saline ke balance solution lagi bagus. Okay, first speed trial in 2015. So this speed trial basically is a study of the effect of the buffered crystalloid solution versus saline on AKI. Macam saya kata tadi, because saline dia ada banyak chloride. So this chloride dia akan reduce in, dia akan menyebabkan renal vasoconstriction which can lead to AKI. So dia nak tengok lah effect ni among patient dekat ICU. Okay, here buffered solution yang dia guna is Plasma-Lyte 148 versus the normal saline. Actually, it's noted that there is no difference between the two in terms of AKI. And then untuk the other one pun dia kata found equal occurrence of the usage of renal replacement therapy, of the usage of mechanical ventilation and mortality between the two. Memang from the study, it is not statistically significant. Tapi kalau tengok the point estimate tu actually dia favourite Plasma-Lyte. Kata Plasma-Lyte is better lah. So that eventually ada another study done in a smart trial after that. This one dia tengok lagi Plasma-Lyte versus normal saline in critically ill adult patient. This is a very large study, okay? It used about more than 15,000 patient. ICU patient. So here we can see that it's actually better untuk sepsis mortality using the balanced crystalloid, and then sepsis MAC30 pun better dekat dalam balanced solution. Sepsis MAC30 ni actually it stand for major adverse kidney event on day 30. Okay, so we can see here dekat trial ni, it shows that there is a reduction in the composite outcome death, the new RRT, and also persistent renal dysfunction at 30 days actually better in balanced solution. So dia pro balanced solution lah. Okay, and then into setelah study juga more than 13,000 patient, but this one study ni dekat non-critically as opposed to the previous SMART trial between critically ill patient. So kat sini they look at the primary outcome of hospital-free days, okay, and shows no difference between the two. Okay, and then it has lower incident or of adverse of major adverse kidney event at 30 days with balanced solution. However, kat sini dia nampaklah macam untuk MAC30 ni dia pro balance solution, tapi dia ada kata kat sini kalau there is actually no resuscitation. What it meant is that kalau untuk first few hours of resuscitation, that means kalau you nak guna less than 2 liters of fluid, actually both of them tak ada significant. Okay, so eventually ada basic trial pula. This trial from 2017 to 2020. This one dia tengok Plasma-Lyte versus normal saline in ICU juga, and this is around about 11,000 patient adult ICU. So kat sini tak ada significant difference in 90 days mortality between the two. Tak ada statistically different of need of IRT juga within 90 days. Tapi SOFA score at day 7 is actually higher dalam saline group. So dia macam in a way dia macam pro sikit dekat balance solution lah. And then plus trial, the last trial in 2022. This one basically tengok again ICU patient Plasma-Lyte versus normal saline. So the primary outcome is tengok 90 days mortality. So basically the Plasma-Lyte or they call balance multiple electrolyte solution lah. Basically lebih kurang sama je, no significant difference, beza 0.8% je. And also there is no significant difference in new RRT, whether the use of vasoactive drugs, days alive and free of mechanical ventilation, and reduction 90 days, all cause of mortality risk of AKI. Okay, so this is the latest one lah. Basically tak ada significant difference sangat lah between these two. Okay, so bottom line from all the study and from the theoretical points that we know regarding normal saline dengan ringan lactate ni, so we could say that normal saline is not superior to ringan lactate. And actually, ringan lactate ni dia more balanced and more closely resemble our serum. Okay, these two trials yang tadi salted and smart trial shows normal saline may increase the occurrence of McT30. So nampak macam longitudinal is a better choice for large amounts of resuscitation. Okay, and then as I aforementioned, lactate ni, lactate dekat dalam Hartmann ni is not lactic acid but sodium lactate, so it can be used in acidosis. Normal saline is non-physiological and contain high chloride, can lead to hyperchloremic metabolic acidosis. So you should avoid in patient yang ada high chloride ataupun high potassium. So from the study also, they suggest that undifferentiated hypotensive patient, you can initially resusc with normal saline, about 1 to 2 liter. And then once the cause or the diagnosis is known, then you can switch to appropriate fluid lah. This depending on the patient chemistry, the estimated volume of resuscitation used, the potential adverse effect of the solution used, and depends dekat your institutional or clinical preference dekat your place. Okay, so moving on, this is just a bit about the difference between ringan lactate or Hartmann dengan Stero. So essentially, dua-dua ni adalah balanced solution. So they have similar composition to plasma. Stero ni more expensive. Okay, ringan lactate ni basically dia punya base access is more and the bicarbonate punya precursor is actually lactate. So lactate ni actually dia metabolize dekat kidney dengan liver. So maybe if patient ada kidney injury ataupun liver injury, we akan opt nak guna sterofundin lah. Sebab the precursor of sterofundin is actually the bicarb precursor untuk sterofundin ni acetate amylate, which actually both of them widely metabolized in all organ and muscle. So in article in 2009 mentioned that in adult patient, actually sterofundin has been shown to be associated with a better preservation of electrolyte and acid-base pattern compared to ringan lactate. Cuma not all ED ada sterofundin lah. Most ICU ada sterofundin. Okay, so moving on to second line. Just now first line kita guna crystalloid. So second line untuk hypovolemic or hypovolemic shock not due to bleeding is colloid solution. This is because of the more rapid plasma volume expansion that the colloid has. Basically kan kita selalu cakap satu colloid kita akan perlukan 3 crystalloid untuk achieve the same effect of plasma expansion. So here I'm basically talking about albumin sebab most of the study done is regarding albumin lah. So albumin ni we have 20% and untuk create albumin 5%, kita boleh ambil 10 ml of albumin 20%, which is satu botol of albumin 20% tu ada 50 ml. So 2 botol akan jadi 100 ml, you tambah dengan normal saline 300 ml. So you ambil 1 pint tu, you buang 200 ml, you tambah dengan 100 ml of albumin, this will create albumin 5%. So basically albumin usage dekat ED ni very limited. It is used for those yang have a limited response to crystalloid solution. Contohnya dalam intractable shock ataupun dalam dengue shock. And then if the hypoalbuminemia ni is thought to be the cause that contribute to the shock. Okay, here I'm just give you the guideline taken from UM. The guideline used for human albumin 20% lah. But mostly yang ni guna dekat ward. This is what lah, contoh kat sini we can see symptomatic hypoalbuminemia, acute hypovolemic shock, then there are the restriction when to use, okay, in nephrotic syndrome. So basically yang ni what punya indication for albumin usage lah. So moving on to sodium bicarb. Okay, so sodium bicarb, we all know that the indication selalu untuk sodium bicarb yang we all already know is kalau ada sodium channel blocker toxicity ke ataupun salicylate acid poisoning. But other indication that we can use is inagma. Bila ada bicarb loss such as dekat dalam RTA. So essentially NAGMA ni normal anionic gap metabolic acidosis kan. Dia adalah deficiency in your bicarb. So it is physiologically sense that kita nak tambah balik dengan bicarb lah. And then we have DKA. So for DKA, this is like macam controversial use kan. Kalau DKA ni kita akan guna usually kalau kita ada persistent pH less than 6.9, then we baru with adequate fluid resuscitation, then we can thought of not giving sodium bicarb in DKA. And then the third one is actually HAGMA. HAGMA untuk high anionic gap, if the patient is having uremic acidosis with hyperkalemia or lactic acidosis with AKI. So actually there is an article in Up to Date. Basically it talks about the usage of lactic acidosis bila nak bagi lactic acid sodium bicarb in patient yang ada lactic acidosis. So it stated ada dua lah basically. Satu, kalau patient tu ada severe acidemia. Having said that, severe acidemia tu maksudnya pH less than 7.1 and bicarb tu 6 or less. So basically you nak bagi sodium bicarb, nak maintain the pH above 7.1. Okay, until the reversal of the underlying cause. Tadi kan as aforementioned before that your principle of management is that you actually nak treat the underlying cause so that you boleh reverse. So basically this is just nak cater for the time before the underlying cause boleh reverse. So you nak maintain the pH, you bagi sodium bicarb nak maintain the pH above 7.1. Lagi satu, kalau in case yang patient yang ada less severe acidemia, that means the pH is about 7.1 to 7.2. Kalau dia ada AKI, severe AKI, then you might consider nak bagi sodium bicarb. This include patient yang ada oliguria and 2 or more fold increment of the creatinine. Kalau yang ni pula, you punya aim is that you nak raiskan the pH above 7.3. So basically for these two, why we are giving sodium bicarb is actually nak prevent the need for dialysis, because we know that dialysis is actually an invasive punya procedure, ada banyak complication, you can lead to thrombosis, infection. So basically if you prevent the need for dialysis, it is said that you may improve the survival. So berapa banyak nak bagi is that it mentioned that you can give about 1 to 2 milli equivalent per kilo. And then you measure the electrolyte blood pH at 30 minutes or 60 minutes. And then kalau tak cukup, then you can repeat, you boleh bagi several doses. But if there are many doses given, then you might consider giving isotonic bicarb. Okay, so kenapa kita nak bagi sodium bicarb is actually kita nak avoid the clinical effect of acidemia. So why? Because acidemia actually can lead to reduce in left ventricular contractility and arrhythmia, arterial vasodilatation, and vasoconstriction, and it can impair response to the catecholamine vasopressor. And all this can lead to hemodynamic instability. So basically you nak avoid the hemodynamic instability, so you bagi sodium bicarb, you nak reverse the acidemia lah. Okay, so you have to bear in mind actually, giving sodium bicarb, there are the potential harms. One of it is that it can increase the arterial and capillary PCO2. So actually you bagi sodium bicarb, so the bicarb dia akan combine dengan hydrogen ion, creating carbonic acid, and then eventually dia akan rehydrate to water and CO2. So eventually PCO2 tu akan naik. Okay, other potential harm is that they akan accelerate the lactate production. So basically, with acidemia, actually lama-lama dia akan inhibit glycolysis. So because glycolysis inhibition, eventually in acidemia, dia akan put brake to lactate production. So when you reverse this process, you actually accelerate the lactate production. Okay, and then it is also said that giving sodium bicarb akan lower the ionized calcium. This is macam dalam alkalosis yang patient yang datang dengan hyperven kan. So datang dengan lower ionized calcium. So alkalization actually dia akan migratekan the what you call this the proton from the protein buffer. So this ionic punya site ni akan attach dengan ionized calcium. So that's why your ionized calcium dekat dalam you punya blood tu akan lower. And then it depends also in berapa banyak you bagi. Kalau you bagi isotonic bicarb, you can create an volume overload to the patient. And then sodium bicarb also can raise serum sodium concentration because you bagi sodium bicarb ni actually bagi dalam bentuk sodium bicarb. So ada sodium juga dekat dalam tu. And then lastly, dia boleh impair oxygen unloading because alkalization akan menyebabkan left shift of the oxyhemoglobin dissociation curve. However, this potential harm, it is said that you can decrease the potential harm by giving less hypertonic solution and then by giving like rate to slower the rate. So you akan lessen the effect sodium bicarb ni kat patient tu. Okay, so the concentration bicarb yang kita ada kat ED, selalunya kita ada 8.4% kan. So this is very hyperosmolar. Dia ada 2000 milliosmol and this one actually memang tinggi lah dia punya sodium punya concentration. And then we can actually create a less less osmolar solution by taking 100 mils of 8.4, adding 200 mils of D5, creating a 200 mils of 4.2%. This is having a less osmolarity than our normal 8.4% lah. And then there is also isotonic bicarb. Isotonic bicarb, as I mentioned before, is actually a balanced solution. Okay, so this one 1.3%. So basically you boleh create this by taking the 1.D5 tu, you keluarkan 75 mils and then you add 75 mils of 8.5, masukkan kat dalam tu, so you akan create a 1.3% isotonic bicarb. Okay, so basically this is like general property of these two. This one 8.4 and 4.2 dia very concentrated, so there's small volume tapi concentration high untuk sodium bicarb dia. So basically you can use dekat patient yang euvolemic ataupun yang hypervolemic yang ada metabolic acidosis because it doesn't cause significant volume overload lah because of the smaller amount. Okay, tapi dia akan increase sodium concentration because of the high concentration level of the sodium. Okay, so like I said before, you nak avoid the potential harm, you actually boleh bagi slow untuk avoid the significant PCO2 rise lah. Kalau untuk isotonic bicarb pula, basically this is you kena bagi large volume, okay? Because there are only 300 milliosmol, 0.88% sodium chloride. So this one, you need a large volume untuk raise the bicarb. So you boleh guna actually untuk patient yang ada acidosis yang under volume. Okay, it doesn't really cause hypernatremia because of the less sodium concentration. And of course, you boleh treat patient yang acidosis under volume, and then you boleh also treat untuk hyperkalemia. Actually, concentration of bicarb ni dia punya effect on the potassium for the patient, it depends on the concentration. Okay, for example, dalam isotonic bicarb, you akan perlukan large volume untuk raise the bicarb. So because of the large volume, which is free of the potassium, you actually akan create a dilutional effect. So dilutional effect ni akan menyebabkan your hyperkalemia tu dilute jugalah. So basically the effect of isotonic bicarb you akan menyebabkan decrease in the hyperkalemia. Okay, tapi untuk disto, because of the hypertonicity, okay, satu is that bila the hypertonic solution masuk dekat our vessel, okay, dia akan menyebabkan water from the cell keluar. Okay, dia akan tarik water. Bila dia tarik water ni, dia akan create a phenomenon called solute drag. Dia akan tarik sekali dengan potassium. So potassium akan keluar, you actually menyebabkan increase in potassium. Okay, tapi at the same time juga, because of the alkalinization, you akan naikkan pH. So bila naik pH, jadi yang potassium and hydrogen gradient tu lah. So basically what you call this, potassium akan masuk, hydrogen akan keluar. So in a way dia akan improve hyperkalemia. So because of the hypertonicity of 8.4, dia cancel out each other punya effect. So you basically tak ada effect sangat on the potassium dekat patient tu. Tapi because of the less hypertonicity of the 4.2%, you menyebabkan dia only a mild decrease on the potassium level. Okay, so basically kalau orang kata macam you bagi 8.4 untuk nak treat the hyperkalemia, is actually wrong. It is better to use isotonic bicarb kalau you nak treat the hyperkalemia of the patient. Okay, so basically the trial that we have yang tengok bicarb usage, this is a bicarb ICU trial in May 2015 to May 2017 lah. Basically, it studied on sodium bicarb therapy for patient with severe metabolic acidemia in ICU. So there are 4 inclusion criteria which include the severe metabolic acidosis patient lah, pH 7.2 or less, PCO2 45 or less, bicarb 20 or less. Kat sini juga dia add on kalau patient ada SOFA 4 or more ataupun lactate more than 2, and then dia akan randomizekan to 2, satu control tak dapat bicarb, satu control dapat bicarb 4.2% bicarb lah. Dia guna 4.2 instead of 8.4 So kat sini is actually a multi-centered open label randomized control using 4.2% sodium. So the primary outcome is actually ditengok mortality by day 28 or the presence of at least one organ failure at day 7. So basically noted that actually had no effect on the primary composite outcome of this. So you guna bicarb ke, you tak guna ke, tak ada beza lah. Tapi dalam subgroup patient yang ada AKI, it is noted that sodium bicarb treatment actually did decrease the composite outcome and 28 days mortality. Okay, and then also there is also no statistical difference in outcome between control group dengan sodium bicarb punya group in the following. In the renal replacement therapy punya 3 days during ICU stay, median vasopressor punya 3 days, dependence on the dialysis at ICU discharge or the length of ICU stay. Okay, basically untuk all this tak ada statistical difference. Okay, and then for metabolic acidosis, hyponatremia and hypocalcemia, which is among the potential side effects of giving sodium bicarb, actually memang observed more frequently in the bicarb group than in the control group. Tapi regardless, with no life-threatening complication. So that was why dalam up to date dia propose untuk in those 2 patient yang patient severe metabolic acidosis or in less severe acidosis yang ada AKI untuk bagi sodium bicarb untuk prevent dialysis. Okay, so last but not least, regarding fluid to avoid. So basically we have 2 types of fluid nak kena avoid lah. Untuk first colloid solution, hyperoncotic starch. Basically it's not recommended untuk patient yang ada hypovolemia or sepsis sebab dia akan increase the mortality and increase the risk of AKI, and in hypertonic saline dia tak ada role in sepsis, dia tak improve survival pun. Okay, so this is just the study lah. Okay, this one, a randomized trial between HES or saline in fluid resusc ICU noted increase of AKI requirement, AKI requiring RRT in those yang guna HES ni lah. And then another one, compare HES juga dengan ringan lactate untuk volume expansion yang in patient yang ada severe sepsis ataupun septic shock. Again, yang ni HES ni ada higher mortality and greater likelihood untuk needing RRT. So that's why dia tak suggest untuk pakai HES lah, kita kena avoid pakai HES. Okay, so overall untuk take home message, basically, delay in therapy in the fluid therapy can lead to ischemic injury and possibly to irreversible shock and then subsequently multi organ system failure. So bila dah ada multi organ system failure, it's very hard to treat the patient, and then patient boleh succumb to death lah basically. So in patient yang ada intravascular depletions because of bleeding, as I said before, you kena bagi blood product lah. Tapi while waiting for the blood product, you boleh bagi crystalloid dulu. And then in patient yang ada non-hemorrhagic punya hypovolemic or hypovolemic shock pula, kalau kat sini dia kata crystalloid is the first line preferred over colloid. And then for initial resuscitation, you might consider bagi normal saline dulu, and then after that individualized according to the patient needs. And as I said before, lactate dekat dalam Hartmann tu bukan lactic acid tapi is a buffer, so boleh guna dalam acidosis. And then normal saline tu actually is a non-physiological containing high chloride leading to hyperchloremic metabolic acidosis, so you should avoid using normal saline dalam patient yang ada hyperkalemia ataupun hyperchloride. Okay, in septic ataupun septic shock pula, yang ni memang tahulah kita ikut septic bundle kan, so kita boleh infuse about 30 ml per kilo of crystalloid prior to bagi a start NORAD lah. And then boleh consider albumin solution kalau contoh dalam leaking dengue ataupun dalam intractable shock. Okay, and then for sodium bicarb pula, the 8.5% yang kita guna tu actually very hyperosmolar, so it's actually not recommended to be given bolus. So the next best option kalau patient tu overload is that you boleh bagi 4.2%. Okay, and then untuk patient yang under volume, you boleh resusc dengan isotonic bicarb. And then lastly, memang clinician should have low threshold lah, basically nak evaluate the type of the fluid depending on the patient punya response and development of the adverse effect. Okay, so here is just like I include here macam table summary daripada Internet Book of Critical Care untuk pH guided resuscitation for those patient yang require a large volume untuk fluid resuscitation. So you boleh tengok kat sini, kalau dia ada basically ada nagma or uremic acidosis, you nak alkalinize the patient, so you boleh bagi isotonic bicarb. Kalau dia ada acute metabolic alkalosis, then you nak acidify the patient, you boleh bagi normal saline. And then untuk yang no pH disorder, treatable with crystalloid, you boleh maintain dengan bagi balance solution lah. Then eventually you need to reassess the electrolyte and volume status. So other one, yang the next one punya ni pun sama juga. This is a summarized table form lah daripada Internet Book of Critical Care juga. Untuk optimal treatment of nagma depends on the sodium and water balance. Macam dekat sini macam tadi kata kan, kalau hypovolemic tu you boleh consider bagi isotonic bicarb. Tapi kalau dia isotonic bicarb ni, dia kan tak ada effect sangat dekat sodium. So you boleh consider nak bagi add on hypertonic bicarb kalau you wanted the sodium. Okay, kalau dia normonatremia, so you boleh consider bagi dia isotonic bicarb je. Tapi kalau dia hypernatremia, then you boleh add on dengan free water lah. For euvolemic, either hypertonic ataupun you boleh consider isotonic dengan diuresis, for example. And then hypervolemia pula, then you kena consider yang less volume lah. So you bagi hypertonic bicarb lah. Then you can add on diuresis. Okay. That's all. So this is my references